Polytrauma refers to injuries affecting two or more organ systems. These injuries often result from external forces such as physical impacts, chemical exposure, biochemical reactions, or psychological stressors. Despite advances in trauma care, trauma remains a leading cause of death and disability among adults. The initial management of polytraumatized patients significantly influences their recovery outcomes. A multidisciplinary team-based approach is required to address the complexity of these cases. The definition of polytrauma varies across clinical settings. The Berlin definition identifies polytrauma as injury in at least two distinct body regions, each with an abbreviated injury scale score of 3 or higher. Additional criteria include one or more abnormal physiological parameters. These parameters are systolic blood pressure less than or equal to 90 millimeters of mercury, Glasgow Coma Scale score less than or equal to 8, base excess less than or equal to -6, international normalized ratio greater than or equal to 1.4, activated partial thromboplastin time greater than or equal to 40 seconds, and age greater than or equal to 70 years. The injury severity score is used to assess trauma severity. A score over 15 indicates severe trauma. Initial assessment. The ABCDE protocol. The initial assessment follows the ABCDE sequence: airway, breathing, circulation, disability, and exposure. This systematic approach improves patient outcomes. Continuous supervision and monitoring are essential. Repeat assessments are necessary as the patient's condition can change rapidly. Electrodes, cuff monitoring, and pulse oximetry should be applied to ensure accurate tracking of vital signs. Airway management. Ensuring airway patency is the first mandatory step. Polytraumatized patients can develop apnea, inadequate ventilation, hypoxemia, and death rapidly. Assess for voice changes, stridor, or obstruction. Examine the oropharynx for foreign objects, tongue edema, blood, hematoma, dental injury, or vomitus. Inspect the neck for asymmetry, foreign bodies, hematoma, maxillofacial fracture, or subcutaneous emphysema. In suspected trauma, avoid cervical spine movement. The jaw thrust maneuver can open the airway if a cervical spine injury is suspected. Oropharyngeal and nasopharyngeal tubes can maintain patency. Endotracheal intubation may be necessary to protect the airway and ensure ventilation and oxygenation in specific cases. Prepare for intubation using the mnemonic stop made. Suction, tools, oxygen, positioning, monitoring, ambu bag, intravenous access, drugs. Alternatives to orotracheal intubation include nasotracheal intubation. Surgical airway management, such as cricothyrotomy or tracheostomy, is the final option if other techniques fail. Cricothyrotomy is preferred in cannot intubate, cannot oxygenate situations. Breathing assessment and management. The second step involves assessing ventilation and oxygenation. Observe the respiratory rate for tachypnea or bradypnea. Check chest wall movement for symmetry or injury such as flail chest. Look for cyanosis and neck vein distension. Auscultate breath sounds and palpate for crepitations or deformities. In unstable patients, a chest radiograph may reveal fractures, diaphragm injury, pleural effusion, pneumothorax, lung damage, or foreign bodies. Exclude life-threatening conditions like tension pneumothorax, massive hemothorax, or cardiac tamponade. Ultrasound can detect pneumothorax. Mechanical ventilation may be required for respiratory insufficiency, lung damage, or airway compromise. Protective mechanical ventilation with low tidal volumes of up to 6 milliliters per kilogram of predicted body weight and plateau pressures below 30 centimeters of water helps prevent ventilator-associated lung injury and increased intracranial pressure. Circulation management. Assess circulation by palpating central pulses, including the carotid and femoral pulses. Compare symmetrically located pulses. Measure blood pressure when skin color and temperature suggest circulatory issues. Insert 2 peripheral intravenous lines for fluid and blood product administration. Obtain blood samples for initial analysis and blood typing. Control external bleeding with direct pressure. Significant fluid loss requires replacement with crystalloids and blood products. Studies suggest a survival benefit with a transfusion ratio of red blood cells to fresh frozen plasma to platelets of 1 to 1 to 1. Be aware of anticoagulant use. Extensive hemorrhage can lead to the lethal triad of hypothermia, coagulopathy, and acidosis. Disability and exposure. Assess the patient's level of consciousness using the Glasgow Coma Scale. Evaluate pupil size and reactivity, as well as gross motor function and sensation. Suspect spinal cord injury in relevant cases and maintain spinal immobilization. Look for lateralizing signs and determine the sensory level. Complete undressing is necessary for a thorough head-to-toe examination. Common missed areas include the scalp, axillary folds, perineum, back, gluteal fold, and posterior scalp. Manage hypothermia to prevent coagulopathy and multiple organ dysfunction syndrome. Point-of-care ultrasound. Point-of-care ultrasound provides rapid diagnostic information in trauma. It can identify free intraperitoneal, pericardial, and pleural fluid, indicating potential internal bleeding or organ damage. Ultrasound has increased sensitivity compared to chest radiography for detecting pneumothorax. In blunt abdominal trauma, ultrasound can detect free abdominal fluid and solid organ injuries. It can also identify fluid around the pelvis in major pelvic fractures, suggesting internal bleeding. Focused cardiac ultrasound assesses cardiac function and can identify pericardial effusion. Standard fast views include Morrison's pouch, sphenorenal recess, pericardial view, and pelvic space. Extended fast adds lung scans to detect pneumothorax. Ultrasound is a rapid, portable, and radiation-free imaging modality. Limitations include operator dependency and the need for specialized training. Sepsis in polytrauma. Trauma can trigger an overwhelming inflammatory response, potentially leading to sepsis and multiple organ dysfunction. The Sequential Organ Failure Assessment Score assesses organ dysfunction. An increase in the score of 2 or more indicates organ dysfunction and a 10% increase in mortality. The Quick Sequential Organ Failure Assessment Score is based on low blood pressure, respiratory rate, and mental status. Monitoring inflammatory markers like C-reactive protein and procalcitonin can aid in sepsis detection. Persistently high or newly spiking levels may suggest sepsis. The initial management of polytraumatized patients requires a systematic and timely approach using the ABCDE protocol and tools like advanced trauma life support and point-of-care ultrasound. Recognizing and addressing airway, breathing, and circulatory compromise are paramount. Early identification of potential complications like bleeding and sepsis is essential for improving patient outcomes.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.